we will get started here. And good evening once again to all of you who are just joining us. My name is Dr. Christina Johns, and I am the Senior Medical Advisor and Vice President of Communications at PM Pediatrics. For those of you who aren't too familiar with us, we are the largest specialized provider of specialized, I like to say that word, focused urgent care for ill and injured children from birth to age 20 through age 26. And we've got over 50 offices across the nation, and we are founded and led by pediatric emergency physicians. I am one, so I'm a pediatrician, I'm a pediatric emergency physician, and I'm a mom. And I'm going to introduce my friend and colleague, Dr. Eric Weinberg, here in just a moment. Many of you met him at our previous webinars, and so now we're all old friends, right? Here we are all together. So I'll introduce him in a moment. Couple of housekeeping comments for tonight, just to make sure that everybody is really teed up to get the most out of this session. First is that please direct your live questions over in the Q&A. So if you go along the bottom of your little Zoom window, there's a Q&A, and so please get into there, open that up. You can vote up questions. So if you see somebody's already asked a question that is your question, give it a like, and that will help vote it up. In addition to Dr. Weinberg, I want to call out to you guys that in the chat, we've got our chat mods, our chat moderators, and those are colleagues of mine who are from PM Pediatrics, who are there in the Q&A specifically answering your questions, individual questions. And they are super amazing heroes. We've got Dr. Parag Vora, we've got Dawn Ritchie, we have Kristen Crandall, Dr. Gary Gerlacher, Dr. Saba Iqbal, we've got Dr. Rich Bruckner, we have Dr. Cheryl Cohen, Dr. Shannon Henning. Did I say Dr. Samantha Jackson? Okay, we have quite a list of experts, and I want to thank them because they are real heroes for this. What we're going to do is Dr. Weinberg and I are going to present for about 20-25 minutes or so that we can get some content out there, make sure we are on the same page, and then after that we're going to take some questions. The submitted questions that you guys sent were absolutely fantastic, so insightful, right on the money. Clearly everybody is reading, and so what we've done, there were so many questions that we've grouped them into themes. Remember that it's really difficult for us to answer very specific medical questions without having examined your child or knowing your child's history. But there are some really some themes that we were really able to consolidate, and so we are going to speak to those in addition to try to get to as many questions as we possibly can. So without further ado, may I introduce my friend and colleague, Dr. Eric Weinberg. He's the Vice President for Education at PM Pediatrics, and he's a dad, and he's a Peds Emerge Med guy like me, and he's going to talk a little bit about himself and get us launched. All right, my friend, take it away.
Okay. Hi, everyone, and welcome back. If I met you several weeks ago, and for those who are new, welcome to our PM Pediatrics COVID informative webinar series. I am beyond excited to say that we have over 1,000 viewers today, which is a new record for us. And I have to say, I was a tiny bit nervous before this, and then I realized I have the opportunity to connect with over 1,000 people, and that is something that is unique and special, and I'm honored to be here today. To speak to you. My job at PM Pediatrics is to take medical information and synthesize it and deliver it for our amazing physicians, nurse practitioners, and physician assistants. And today what I would like to do is take some of that same information, synthesize it, and deliver it to you, patients, families, and children out there, so you can make informed decisions and best live your life. So without further ado, I'm going to share screen and we'll start talking. Okay. Dr. Johns, are we good?
We're good. Roll them.
Okay, let's get started. So I always start off with some objectives, what we're going to talk about today. We're going to begin with the symptoms of COVID-19, specifically in children. Then we're going to focus on the risk of serious illness in children because the risks are different than compared to adults. We're going to spend a fair amount of time, probably half our lecture, on this new syndrome called multisystem inflammatory syndrome in children. I know probably about 30% of our questions focused on this very condition, and we're going to give you as much information as is out there so you can be prepared and ready for it. We're also going to tell you the warning signs of serious illness and, most importantly, how to protect yourself and your family while still living your life. So to begin, what symptoms can you have with coronavirus? Sorry, let me just minimize here. Okay, so there are 9 symptoms that are described with coronavirus that are identified by the CDC. The big 3 are fever, cough, and shortness of breath. The hard part is kids often present atypically with all diseases, and this is no different. So studies have shown kids only present with fever or cough about 70 to 80% of the time. The remainder of the time, they may present with these other symptoms, most notably throat pain or redness. They may present with GI symptoms as well as headache, muscle pains, and notably loss of smell. Specifically, this loss of smell and taste, commonly referred to as anosmia, is actually a hallmark of COVID-19, and that means it's a symptom that's not commonly experienced with almost any other condition. And so if we have a patient, I've seen many of these patients in telemedicine and in real life who present with this loss of smell or taste and do not have any symptoms of sinusitis, and no sinus congestion, no sinus pain, then the most likely diagnosis is going to be COVID-19. And there are estimates that approximately 30% of patients with COVID-19 will experience this symptom. The good news is this appears to be transient and can recover, although it can take a fair amount of time, weeks to even months, to come back. Another symptom you may have heard about in the lay press are rashes. So approximately 20% of COVID-19 patients may develop a rash at some point. And this rash can manifest in a number of different ways. It can manifest as mottling or livedo reticularis. It could manifest as hives or urticaria. One thing we got a lot of questions about is COVID toes. This is something I've seen personally in my patients, and it's an inflammation of the toes. Typically redness, swelling, some minor pain, and even potentially blistering. And it's thought to be caused by inflammation. So it's not a direct result of the virus itself. It's inflammation that causes a small amount of damage to the miniature vessels in your toes. And that's why you experience this pain and discomfort. And that's why it takes so long to go away. There was a question that was submitted about whether you should go for testing if this happens. And my answer to that is yes. I would recommend PCR testing if you do see this. Even if that's negative, which it may be because it may not be active infection, I would encourage you getting antibody testing several weeks later. And we could talk about antibody testing in the question and answer. 2 key points to take away from this slide. If you just have rash alone, and I'm seeing a lot of panicked parents out there who call up with a kid who looks amazing, has no other symptoms, and just has rash. And this, as a pediatrician, as a pediatric emergency medicine trained physician, is not concerning to me. However, if you have rash and fever, that could be a symptom of this multi-system inflammatory syndrome in children, which Dr. Johns is going to go into in a couple of slides. And we'll talk about what to do if you see that. But the short answer is, if you see rash plus fever, please seek a medical evaluation. Are kids at risk for serious illness? The reassuring and the good news for all of you out there, I assume there's a lot of parents in this crowd, the answer is usually no. Serious illness in children is less common than adults. Kids, there's 2 facts I want you to remember. One is that kids are less likely to get the illness overall. They only represent about 2% of cases. And even if they get sick, they're much less likely to get serious illness. Just looking at some New York data, as this is the epicenter of the country currently, children only represent 1% of hospitalized patients in New York. And of those children who end up hospitalized, the great majority have pre-existing conditions, approximately 70 to 80%. And only a few of these patients will end up requiring intensive care unit or ICU admission. One thing to keep in mind, infants are at slightly higher risk, although still compared to adults, the risk is relatively low. What is the mortality rate of COVID-19 in kids? And the reason why I'm adding flu here is I'm seeing a lot of comparisons in the lay press of coronavirus to flu. And as a person who kind of lives his life in science, logic, and reason, this is a bit disturbing because the mortality rate compared to flu is quite different. And you'll see that in the next slide. So this is some early data from China, which has actually been validated in several other studies in several other countries. Their overall mortality rate was approximately 2.3%, with a great number of patients who have this unfortunate outcome with pre-existing conditions, similar to the New York data. The thing I want you to focus on here, because we are talking about children, is the low rate in the 0 to 10-year-old. It's actually 0%, and even 10 to 19 is 0.2%. And that number remains low until you get up into the 50 to 59 range, where it starts to increase. I want you to remember two caveats about the data in terms of the coronavirus mortality rate. One is that many mild cases likely go undiagnosed because they're not getting tested. So this would, in effect, lower the mortality rate. And the second factor is that many deaths can occur that are not attributed to COVID-19 because they're not tested. And this could actually increase the mortality rate. But if you put all these numbers together, the true overall mortality rate is likely approximately 0.5 to 1%. Now, this doesn't sound like a lot. And, you know, there's always lies, damn lies, and statistics. But I want you to compare this number to the mortality rate of flu. So the last pandemic, influenza, which was back in 2017 to 2018, the mortality rate was anywhere between 0.02 to 0.1%. So the mortality rate of coronavirus is 5 to 50 times higher than pandemic influenza. So this is clearly much more dangerous than the flu and warrants a very different type of lifestyle and type of practice. Some other data just to validate the earlier ones and to hopefully reassure you a little bit. I chose data from South Korea because this country is testing better than any country in the world, and likely their data represents a closer picture of what the real numbers are. And if you could see on this chart, there's an absence of a certain age group, and that's the less than 30-year-olds. And the reason why, so this chart is actually the percent mortality by age. And the reason why this number is not represented is because there are no recorded deaths in less than 30-year-olds in this country. Okay, so that again is something that hopefully reassures you that children and young adults are at lower risk. Why are kids lower risk? To be honest, nobody knows. There are a couple of theories. One is that they may have less receptors for the virus in their lungs, called the ACE2 receptor, and this is what coronavirus uses to enter the cells of the lungs and other parts of the body. The second theory is that kids may have a higher level of antibodies to the virus that's acquired. So as any parent knows, kids get sick on a regular basis, especially in winter. And a lot of these illnesses may be caused by other coronaviruses. There are 4 coronaviruses that actually cause the common cold. And if you get this, there may be some kind of acquired immunity, although again, this is just theory and not reality. So that was a little bit of review for those who tuned in previously. There was some repetitive data, but I felt like it's important to frame the discussion. And now we're going to present completely new data to you. And I'm going to hand it off to Dr. Johns, and she's going to talk about multisystem inflammatory disorder in children. Dr. Johns.
Great, thank you, thank you. So let's talk about this a little bit, and let's dial ourselves back in time, just about a month or so. And for those of you who know me well and have been following along with me, initially we were really, as pediatricians, really stunned by the fact that kids didn't seem to be getting infected very seriously at all. There seemed to be low numbers and low severity, and that really surprised us. And then, in fact, we started hearing initially in April, and in Italy, mostly also in the UK, that there were a cluster of cases of this Kawasaki-like syndrome. So this constellation of very critically ill children who had fever and a variety of other symptoms, some abdominal symptoms, rash, etc. And so we started to take note of this, and was this in fact related to COVID-19? And so that was something that really got our attention. In May, we started to hear about some of similar cases reported in New York And then, of course, as it has gone throughout these first couple of weeks, those numbers have increased, as we all know, because we've heard about that on the news. Initially, this was called pediatric multi-system inflammatory syndrome, PMIS. There have been all different kinds of confusing mnemonics, and now it is MISC, multi-system inflammatory syndrome in children. So as of today, from the early New York data, in New York alone, there are about 137 cases, and about 90% of them have been linked to COVID. And in fact, we need to change our slide, sadly, for the mortality data, because in fact, it has now gone from 3 to 4. And there was a teenager in Baltimore who sadly died from this today. So let's talk through with our next slide. Dr. Weinberg is advancing that. The CDC definitions very strictly is that this is seen in children, in people less than 21 years old who have fever, and lab evidence of inflammation. For all of my healthcare professionals out there, that's an elevated ESR and CRP, some transaminitis, so your liver enzymes are elevated, amongst other lab abnormalities. These children are largely quite ill appearing. They require hospitalization. Many multi-system organs end up being affected. There are no other diagnoses, so this is a diagnosis of exclusion and a link to, of course, to COVID. So in terms of, that's fine. That's what the CDC says. So what do we want you to know? Okay, what's really important at home? And that is, I want you to really pay attention to fever. We are really, that seems like a really broad thing to say, but in fact, we are really paying very, very close attention now to patients who come our way in office or via telemedicine, who have fever and who specifically have fever for several days in a row, plus any of these. So the abdominal symptoms, like I suggested, vomiting, diarrhea, abdominal pain, who are in fact shocky. So they have poor perfusion. What that means is they're not having fantastic blood circulation throughout their extremities and have cold hands and feet, an elevated heart rate, kids who have a chest pain, trouble breathing, who might not be acting like themselves, skin changes, any kinds of rash, pink eye. Those are some of the other symptoms that, in fact, we want you to keep an eye out at home. If you're starting to see this constellation of symptoms together, then it's very important to seek medical care so that you can let your healthcare professional, a clinician, a healthcare professional, be your guide to decide what needs to happen next. So then where the heck does this Kawasaki's disease business come in? So Kawasaki disease is something that we in pediatrics have been treating and managing and diagnosing for quite a long time, in fact. And what this is, it's really an overactive immune system and inflammation that we believe that happens post-viral. So it means that's after a viral infection, not during a viral infection. And it is also, Kawasaki's tends to be quite rare. And there are very strict criteria to make the diagnosis. So a very prolonged high fever of more than 5 days, plus rash, swollen glands or lymph nodes. There's the famous strawberry tongue or cracked lips, red eyes or conjunctivitis, some skin peeling. Those are the hallmarks. There are, of course, nothing in medicine is 100%, so there are atypical cases, but by and large, that's the textbook case. And you need to have some of these criteria, in fact, to make the diagnosis of Kawasaki disease. So is Kawasaki treatable? Absolutely. We bring kids into the hospital. They are treated with an IV medicine that helps to settle down the immune system called IVIG, sometimes with steroids as well. And since we started to see kids who have this similar constellation after COVID, the link really became very, very clear. The concern here is that children untreated who have Kawasaki who go untreated, in fact, can have inflammation and irritation in their coronary arteries and obviously in the heart that can lead to some significant problems and failure and circulatory collapse. So that is really the concern. So is this being seen? Are we seeing a similar pattern with MIS-C? Indeed, we are. So what is happening? So, and why is it happening now, right? That we asked our questions and not back in March and April. So what we think, again, to reiterate, that it's a delayed abnormal inflammatory response that happens days to weeks, most commonly about 4 weeks later after the acute infection. And we see inflammation in different organs in the body. So there's skin changes, right? Skin is our largest organ. So we see changes there, and rashes can affect the liver and kidney. And of course, the biggest concern is in the heart. So myocarditis, which is an inflammatory process in the heart itself, the heart muscle. And so that affects the ability for the heart to pump. And in fact, if the heart doesn't pump well, then obviously there are significant problems and can be critical illness. And these are the children who you are hearing about and seeing on the news who are requiring ICU support. And they're in the ICU. So who is getting it? Let's take a look at that for the ages. You can see that here's the table here. And by and large, this tends to be a phenomenon. We're calling it school age kids, right? If you look at those percentages, the large majority are kids from preschool all the way up into the teen years. And it tends to skew just a little bit older than Kawasaki, but still clearly does overlap. So those are the most common ages. So spread out, but all throughout the pediatric population. Okay, and moving on. So let's talk about the overall risk now. This is some quick math here and some approximate math using New York data. If there are about 19.5 million people in New York State, in the state alone, and about 21% of them are less than 18, that works out to about 4 million children. And so if we look at today, where there are approximately 137 cases of MIS-C, that works out to 0.003%. So about 3 out of 100,000 children have this illness. So again, while we are really saying we want everybody to know about this and to be very aware of what's going on with your own children, really it's quite a low risk. And that most kids, even kids who have COVID, really do just fine and recover well. So we want to be measured about this. We are watching this data as it evolves. We're watching what numbers of kids, in fact, have this constellation of symptoms, this MIS-C. There appear to be more, but overall, the risk is still very low. And I say that to be reassuring because I think that is appropriate when we look at the overall data. Okay, so keeping on going. So management, what is this treatable? And in fact, yes, it is treatable. And kids certainly appear to be having better outcomes if treated early. So if there are children who have fever or any of the concerning signs that we talked about, and again, I'm going to just say them out loud again: abdominal symptoms, nausea, vomiting, diarrhea, if they've got any kind of a rash, or the whites of their eyes look pink or red. Those are concerning signs. That constellation of symptoms, we really encourage you to get checked out right away. If a clinician suspects, in fact, that it may be this MIS-C, then a whole battery of blood work is obtained, typically chest x-ray and EKG, other tests, a cardiac echo, which is an ultrasound of the heart, as well as some specialty consultation takes place fairly quickly, because we are really keeping track and want to find these children very early on. Typically they get hospitalized, and for those for whom they have some of these diagnostic criteria, then they get this IV treatment right away. And that's an important thing. So can be treated. It does require hospitalization because it's an IV medication, and many children need to have ICU support. That means intense close monitoring. Some need to have blood pressure support on IV drips, and some need to have respiratory support on the ventilator. But as I'm sure you've seen on the news, like I have, that there are children who have undergone treatment and who have recovered. So that is an important note about that. Let's talk a little bit about serious illness, because the one thing that those of us who are the Peds Emerge guys here in the crowd always think about worst case scenario and try to get prepared. And so what items that make us concerned for me, if I hear that a child has had fever for multiple consecutive days, very concerning to me. Fever plus any rash, vomiting, abdominal pain, put those things together, and I want to hear about that right away. Any trouble breathing, chest pain, especially along with fever, that is concerning. And of course, a late finding, but signs of shock. So a child who's confused, not acting like themselves, cool, pale, clammy skin, obviously that is something that would concern us as well. And you know, my feeling about it, honestly, is this is where I trust parents, my word, right? This is where parent instinct is an important element here. If you have a sense that something just isn't right with your child, trust it. I know that I try to do that with my kids. And I think, Dr. Weinberg, that's probably the case for you too. As I pass the torch back to you to bring us home, I'm guessing you agree with that, right? The parent's instinct. It's something that we trust and we need to listen to.
Absolutely. So I think just to echo Dr. Johns, one of the major take homes of this lecture, we are asking parents to come in and be evaluated maybe a little bit earlier than we would have in the past. And the reason why is that, as you can see by some of these symptoms, you know, fever and a little bit of vomiting or fever and diarrhea in the past, I don't think I would be concerned at all as a pediatrician. I think most parents would not be that concerned either. But unfortunately, there's a lot of overlap between mild viruses and the development of this syndrome. So you really need expert eyes to determine if there's the potential for something more serious. And I would encourage people to come in a little bit earlier than normal. So when and where to seek care if your child has fever, rash, vomiting, mild abdominal pain, or even cough or throat pain, I would recommend at a minimum a telemedicine evaluation if you're not comfortable coming out. But to be honest, I think I would recommend an urgent care or an evaluation at your pediatrician's office. If your child, on the contrary, has difficulty breathing, cool hands or feet, poor color, or severe abdominal pain, at that point, you're really best served in a pediatric emergency department that has, is able to handle a higher acuity and can do a further workup that is necessary. How do we fit in? So Dr. Johns, myself, and a lot of the physicians and nurses on this webinar, we all work at a place called PM Pediatrics, as you now know. And we can help you with this. We have over 50 offices in 13 states. Our offices are built to keep you safe during the COVID crisis. A great majority have stayed open throughout. We could do safe medical evaluations. We do extensive cleaning both in between patients and at night after patients leave. We also focus on keeping the waiting room completely empty and bringing patients back into the exam room or having them wait in cars so that you're not around people who are sick. We also offer the ability to do both PCR and antibody testing. We'll talk about which one to do for which settings in the question and answer, but you have the ability to get these done at our offices because, again, we look at ourselves as pediatric specialists compared to some other places. The other thing you can do if you're nervous about leaving, we do have our PM Pediatrics Anywhere app where you can get a virtual visit and you could be evaluated either medically or evaluated for testing at the same time. So we're going to switch gears a little bit and we'll finish with how to protect yourself and your family. So I know we presented some scary data and none of us here are alarmists. We just want everybody to be aware, but keeping in mind that the percentages of this in the general population are still quite low. Nonetheless, we all want to make sure that you're protecting yourself as much as possible. So a big take-home message is to continue social distancing, even when your state says from a institutional level that they're no longer doing that as regimented as they were in the past. So there's a lot of mixed data about whether kids have to socially distance and whether they're implicated in the spread of the virus. And it goes in both ways. So as we've shown, kids seem to get less COVID-19, which is a good thing. But the problem is they tend to have lots of contacts. And those contacts, they tend to be very physically connected with. So there is a theory that children as well as adults can spread this virus. So I think social distancing has to be for both children and adults as much as possible. There is some debate, which I think is we can put to rest right now about whether social distancing actually works. There is a very nice study of every single county in the United States, over 3,000 counties, and looked at the virus rate in counties that used social distancing and implemented it and those that didn't. And those that did reduced the virus rate by about 10 to 35 times. And that equaled less mortality. So again, even if states open, I'm encouraging everybody in this call to practice social distancing, but on a personal level. And the way I'm going to guide you, I'm going to steal this from a colleague. His name is Atul Gawande, and he is a Boston surgeon and public health advocate and a very eloquent writer. And he wrote this article in the New Yorker on May 13th that really framed how to do social distancing with your family and personally into 4 pillars. And those are hygiene, masks, distancing, and screening. And when we talk about screening, we mean testing for COVID-19. And the way he wanted everybody to think about this is to protect yourself like you were a healthcare worker. So we've put in a lot of changes in our practice, and hospitals have done the same. And these have been very successful in keeping the rates of infection among healthcare workers low. So we want everybody in the public to do these same things. And we're going to go deep into each one. So again, keep in mind, social distancing, less virus, less deaths. So first up is hygiene. Why is it so important to wash your hands? This is a flashback to our previous lecture, but I think it's important to repeat, is that coronavirus can survive on many different surfaces, from 4 hours on metals to up to 3 days on plastic. And cardboard specifically, for anybody who's getting deliveries, it can survive on cardboard up to 24 hours. One study I found since the last lecture when I spoke to you guys is it matters not how much, like how well you wash your hands, it matters how frequently you're doing it. So there have been several studies of both respiratory viruses and the original SARS outbreak that showed if you wash your hands more than 5 to 10 times per day, you can decrease your risk of getting sick by about 50% or more. So this is a critical point that I hope everybody can take. The second pillar is masking. There's a lot of debate about masks, and I would also like to put that to rest here. There is pretty conclusive data that masks actually decrease spread. There is data suggestive from the first SARS outbreak as well that those who wore masks, again, decreased their risk by about 50%. In addition, there's ample evidence that countries with high mask use, for example, like Hong Kong, have a very low virus rate compared to the United States, which leads the world in cases. Again, keeping in mind, and I mentioned this many times in previous lectures, the virus is often spread by asymptomatic people, either patients who don't get any symptoms at all, or those who are asymptomatic for about 5 days before your symptoms begin. So you may not know if you have it, and you could unwittingly spread it to other people. And surgical masks, although they're not very good at protecting you from other people, they don't make a very tight seal, they're actually built specifically to prevent you from infecting others. So the best way to think of a surgical mask is for their original intent. If you look at the picture here, surgeons wear surgical masks because they're trying not to get their patients who they're operating on sick. And these are very good at what they do. They tend to block almost all particles from coming out. So it's really about protecting others from you and not protecting you from others. I think this is about people helping people. This is a show of respect, and this is a social contract where we're helping each other. Another pillar that I would like to add on, we'll call it Eric Weinberg's pillar, is to be smart, not scared. And I also mentioned this in the previous lecture, but I really try to remind myself of this, especially when I feel my own brain starting to spiral out when you hear about these bad cases or you read about a scary case, you know, in the New York Times or other papers. I try to remember to be smart, not scared. And some ways to do this are to avoid things that aren't really going to help you. So for example, I would not recommend washing your food with soap. It's more likely to make you nauseous from the soap as opposed to protecting you. We find that gloves are mostly ineffective unless you're in a healthcare environment. Once your glove touches a surface, it's no longer protectant, it's now part of your hand. We also do not recommend routinely washing your shoes or wiping them down. You're going to take whatever on your shoes and put it on your hand and likely transmit it to your face. If you do work in a high-risk field, I would recommend changing your clothes and washing up when you get home before being in contact with your family. One thing I've learned recently is to consider purchasing a home pulse oximeter. And this is a handheld device. It's about $30 to $60, and it can measure the oxygen level in your blood. And the reason why is that a lot of physicians started noticing that patients were coming in with incredibly low oxygen levels that they've never seen in somebody who is awake and alert before. And the theory is that this oxygen level goes down very, very slowly over time without the patient actually realizing that they're getting more sick. So if you come down with a fever or cough or something like that, I think it's helpful to look at your oxygen level. And if you see that it's trending down, you can get treatment earlier before requiring a ventilator, because once you're on a ventilator, it's very hard to come off. Other advice for you in terms of being smart, you can consider takeout or curbside service. As states open, this is going to become regular practice for all of us. But what I would recommend is take the stuff out of the package, throw the packaging away, and then wash your hands. One question we get all the time, both in real life, I struggle with this with my own family and friends and my need to connect. And we read this question many times in your submissions. And unfortunately, I don't think there's a lot of people who have the guts to get out there and tell people what they think they should be doing, but we're going to try to do that for you. Again, understanding that this is our informed medical opinion and not fact. So can you meet with friends and family? I think the answer is maybe, but again, be smart. So obviously follow your state regulations, use the pillars that we talked about, hygiene, masks, and distancing. And when we're talking about distancing, you really got to keep in mind that 3 to 6 foot distance. And this was actually derived from other illnesses like meningitis and strep. They looked at meningitis outbreaks and they looked at strep outbreaks in the Army, and they saw that people who were greater than this 3 to 6 foot distance away had much lower risk of infection. One way to guarantee that distance, I'm a self-proclaimed sort of pyromaniac, and I love getting around a fire, and a fire is a perfect way, if you have that availability, to space yourself from somebody else without feeling like you're very far away from them. So I know people in my neighborhood are doing that. I don't see significant harm in that. But again, I think the keys here are keep it outside. There is ample evidence to show if you're inside for a prolonged amount of time, your risk of infection goes up significantly. I would keep these groups very small. The more people you have, the more chance you have of getting infected or infecting somebody else. And you really want to refrain from any physical contact if possible, to reduce the chance of your spreading the virus. And then for those of you who have family members or yourselves who are vulnerable in some way, I would consider a quarantine before seeing anybody, any of these people. So for example, and I think I gave this example last time, for trying to introduce my kids to my parents or their grandparents, we're going to quarantine tightly for 2 weeks. And then we are going to have them see them once the state opens up and things relax. And I think, look, we're humans, we need connection. I think we could do it in a smart way. So some take-home points. I know we reviewed a lot of data today, just things we want you to remember. Take-home point, kids and young adults are low risk for serious illness. Multisystem inflammatory syndrome in children is rare, but can be dangerous. We want you to watch out for the warning signs of persistent fever, rash, GI symptoms, pale skin, or trouble breathing. If you have any concerns, we really encourage you to get a medical evaluation via telemedicine, urgent care, your pediatrician, or the ER if your child looks quite ill. And as states reopen, I want you to really continue personal social distancing. And this means hygiene, masks, distancing, and my last pillar that I'm adding on there, which is to be smart and not scared. Thank you and stay safe.
Great. Thank you for that. That was a lot of info to chit chat about here in a short amount of time. But now what I thought that we could try to do, I see that excitingly, looks like we've had over 200 questions already answered in the Q&A. So we are motoring our way through. But I want to start with some themes that I thought you and I could kind of talk through that I hope will be helpful for everybody listening in. Okay, first of all, everybody is dying to know from the last couple of sessions back about the vitamin D. So can you talk through a little bit, number one, about the thought thought about quickly about the rationale, about the fact that is this an evidence-based recommendation, and what the dosing is, and say it slowly so people can remember it. Okay.
So I'm glad. I felt a little bit bad after the last lecture. I wanted to add in one statement to my previous recommendation, which is, especially if you're an adult, I want you to consult with your doctor before starting any of these high dose regimens. But so a couple of details for vitamin D. There is a theory that it helps, and this is based on the fact that there are several studies that suggest patients who have worse outcomes and higher mortality tend to have decreased vitamin D levels. This is especially notable in the elderly and those with pre-existing conditions. So to me, when measuring whether to do something, you have to think about risk versus harm. And there's really not a significant amount of risk of taking vitamin D. And there's potential benefit, so I think risk benefit wise, I would lean towards taking it. We recently purchased a bottle off of Amazon. In terms of adults, if you suspect that you are low, I certainly suspected I was low based on the amount of time I've been spending outside, which is not a lot,
right?
Based on how busy we've been. So for those of you who may be low, you can start with 10,000 units per day for several weeks, and then go down to 5,000 units going forward for another several weeks. For those of you who are on vitamin D already, I've gotten this question from family, I would recommend just continuing the regimen that you're on because you're likely not deficient because you've already consulted with a doctor or you've read recommendations. In terms of kids, you have to adjust those numbers down. So the dosing for kids would be approximately 2,000 units per day, just every day going forward.
Yeah, and Dr. Weinberg, what about data in children, where this is mostly extrapolated, right? Because I think it's important to really say that, right? For true kind of evidence-based medicine, we really need to look at study population when we analyze the data, and so I think that's really a fair caveat that we should probably make too.
I appreciate you mentioning that. This study is really just in adults, so. I would, my children are not on vitamin D. They're actually going outside while I stare at my screen and do work all day. So they're getting plenty of vitamin D, I think. But unfortunately, some of us, either who are working their butts off or have other conditions, may be lower, and this would be a good candidate for them. But that's an excellent point.
Yeah, an important one, and we've gotten a lot of questions about that, so I'm glad we had a chance to talk about that. Really quickly, we'll get back to MISC here in just a minute, but there were a bunch of questions that people wanted to talk through a little bit about the different kinds of tests. When should I get this kind of test and that kind of test, and what does it really mean? So let's kind of talk through that one together a little bit. So let's first talk about the test that, and what the kind of a nice way to break it down a little bit is the test that you really probably ought to get if you've got symptoms, if you actively have symptoms. That's the PCR test, right? That's the nasal swab. All right, you want to take it from there and tell us about that one first.
Perfect. So we offer both at PM Pediatrics, and to be honest, their testing is pretty widespread at this point, but we find ourselves that we're good at doing it in kids. So that's
right.
But I agree. So any symptoms of illness, I would recommend getting a COVID-19 test, and that would be a PCR. Typically that's done with a nasal swab. There are some places that are doing oral swabs as well. We're still waiting on some data before we switch to that as a practice, but that may become more commonplace as we go. And that test typically takes about 2 days to come back. I would caution people from using the rapid form of any test, either PCR or antibody, is their reliability is still in question. And if you're reading about an unreliable test, it's usually these rapid ones. Flipping the script a little bit for those who think they may have been infected in the past, or those who may have been in contact with someone who had coronavirus a month ago or 3 weeks ago or 2 months ago. We've had a lot of patients with that. The best test for you is an antibody test, specifically IgG. And what happens is the body takes several weeks to generate this antibody, and then we do take a blood sample and we look for whether this antibody exists in your body. Now, the question that comes up more often than not is whether this antibody equals immunity. And unfortunately, the answer is we cannot be sure yet. We hope it is, and based on other coronaviruses, there does seem to be immunity after the first infection, and there does not seem to be a common relapse. So we are hopeful that if this antibody test is positive, that it equals immunity, but we cannot say that for sure. What we can say, though, is if this test is positive, that means you likely had the infection in the past. And for me, I would probably sleep slightly better that night knowing that information. So I think that that information is powerful and can be very helpful for families. We do testing for antibodies and PCR for all family members, not just kids, because we really want to serve everybody and not
Yeah.
just isolated.
And you know, I think it's a really important thing too, is just to kind of call out the public health service here, that I think it is incredibly important that we have some understanding of infection surveillance and what is a better understanding, put it that way. I know that all of the agencies are really doing their best, but I think that is something that is not as well understood as we would like. And additionally, in children, I think that's even more so. And I think that's where we, as an organization, I know that we feel that there is value in that mission alone. And I think that's important. It's important for us to understand the denominator. I know that a lot of people have asked in the chat, in the questions about, hey, how common is COVID in children? And the fact that that's a really tough question for us to answer because we don't have enough of a testing sample yet. I think to really make terribly smart and accurate conclusions about that. So I think there's a lot more work that needs to be done. I know a lot of people have asked me, hey, well, gosh, what the heck? Why would I want to get this test right now if we're really concerned that, you know, they aren't perfect tests? Number one, no test is perfect. We have done a lot of work, I think, in our organization, making sure that we aren't using these rapid tests. We use the tests that have the high reliability, that are the ones that the FDA has, all the letters again, that are on their EUA, Emergency Use Authorization list. And those are the tests that can be validated at a high complexity lab. And those are important for us to be using only those. And I would really encourage people to only do that as well, so that you can get the most accurate results that you can.
Absolutely.
Yeah. So another common question is, why do some people not get why would you not get an accurate antibody test, or what does that mean? Can you help sort that a little bit for people? Because I think that's only fair. Yeah.
Absolutely. So the antibody test, there's two terms that you may hear about a lot, sensitivity and specificity. So the antibody test is very specific, and that means if the test is positive and you're getting it at a reliable laboratory, like a LabCorp or Quest or a major hospital center, that means if the test is positive, you're 98, 99% likely to have had that infection. You can trust that result. For antibody testing, the sensitivity, which is the rate of false negatives, is a little bit lower. So the sensitivity of the test we use is somewhere between 80 to 90%. That means 10 to 20% of the patients who are tested negative may end up testing positive at a later time, because either they tested and pick up on it, or it took a little bit more time for their body to generate a response. In terms of the PCR, the accuracy is actually relatively similar. They're very specific. If the PCR is positive, you have it. If the PCR is negative, there's actually a 30% chance that you may still have COVID-19, and I would still recommend doing antibody testing down the line.
Yeah, that's a really important one to make. It's important to know the difference, and I do think that getting the test now, again, aside from the general good of society, I do think that the science is going to catch up, and we are going to learn more and more about what this means to have a positive antibody. And so I think that having that knowledge in your back pocket is going to be helpful, especially.
Absolutely. And I could even say, you know, at this point, we're gathering enough data where we can make some of our own conclusions. And we could say, like, in the populations that we've looked at, our antibody positive rate and we've done thousands and thousands of tests. Our antibody positive rate is about 15%. And that means 15% of the people who were testing had infection in the past.
Right.
And in terms of our PCRs, the rate is about 20%. And that means 20% of the patients who are coming in for PCR testing actually have the active infection. So those are our numbers, and the more tests we do, the more accurate they become.
Yep. That's right. Okay, shifting gears, I want to make just a quick hit comment about kids with asthma because everybody's asking about that. And here's what we know. The early data indicates, in fact, a surprise to all of us who were absolutely convinced that kids with asthma and other chronic respiratory conditions would be at increased risk for COVID-19. And in fact, the early data, and again, I am emphasizing this is early data, indicates that that's not the case, that in fact they have the same, the equal risk as kids without asthma. So what does that mean that your child is not at risk? No. Does it mean that you need to not worry about it? Of course not. I think the most important thing that I'm recommending to people who have kids with asthma is the best way to manage this is to work on your prevention plan. So work on your asthma action plan with your healthcare professional to make sure that you're preventing asthma attacks in the first place for many different reasons. But the good news for kids with asthma is that it does not appear that they are at increased risk. So I think that's an important one. We got to hit that and close that down right away, right? Yeah. Okay. Anything? Did I hit anything else to add on that topic?
No, we could add on that the top three comorbidities or pre-existing conditions that put you at risk are obesity, diabetes, and hypertension.
Right, and that's an adult. That's an adult.
That's
right.
correct.
Okay, so we'll be really clear about that. Another comment that somebody asked: what about the kids with the MIS-C? Are they by and large kids who have pre-existing conditions? And I think that answer is no. There are many kids who are healthy. Yeah.
Unfortunately, no.
Unfortunately, no, that's right. So these are children who do not have any underlying medical conditions, which has, again, I think this has really surprised us in many different ways. Okay, so let's go through now. We got to talk about schools and we got to talk about daycares and gosh, where do we even begin? Okay. All right. Let's do schools. You start. I'm putting it on you. You take it away.
I like schools because I think it's a slightly easier answer.
I do too. Go ahead.
And again, please take our opinion as just that. I think our opinions are informed, but they are not fact. And the knowledge of this virus changes on an hourly basis. So, but based on what we know right now, I would lean towards trying to open schools in the fall. The reason being is that I think as a society, we need schools to survive. I think our kids need school. Certainly my children do. They need school to learn, they need school to socialize, they need school to grow. And from a societal standpoint, parents need school because they need to work. And so because it's such a critical part of our society, I think we have to realistically understand that maybe it increases the risk of coronavirus by an incredibly small amount, but we can tolerate that in some way because school is so important. And again, this is just an informed opinion. This is not fact, but this is where I'm leaning towards today. That may change tomorrow, and ultimately it's not up to me. It's up to the governments and so on. But I think they're struggling with the same decision of balancing risk versus benefit to society. And I think, Dr. Johns, we talk about this all the time, and we mention it, I think, in every webinar, is we can never eliminate risk in our society. All we can do is minimize it. So do I think schools are going to open up and look exactly the same as they did before? There's no way. There's going to be masking. There's going to be very strict hand washing. There's going to be distancing. There may be staggered days and half days and smaller class sizes and so on. But I think it's going to open in some way, shape, or form, is my personal opinion.
Yeah, I think so too. And I think we also really need to call out that schools also provide for a lot of kids their good meals, healthy meals for children who deal with food insecurity. And so I think there are a lot of reasons and a lot of incentives that we really do need to work towards that. And I think I've been very impressed so far with what I have seen with schools being very clever and creative in terms of figuring out modalities that to make it safer to return, to minimize that risk. Again, we're back to that minimize versus eliminate risk, to minimize the risk. And that is having kids who are in school 1 to 2 days a week, remote schooling 3 days a week,
Right.
or in 1 week out for 3. I know that that's being tossed about. There are all different kinds of screening in terms of more regular temp screening. And again, is that a perfect thing? Because can kids be asymptomatic and have COVID? Indeed, we know that to be true. Are any of these foolproof? Probably not 100%, but I do think that some of these measures really will, in fact, be put in place and be workable, and we will figure this out.
Absolutely. If I could add 2 things.
Yeah.
One is that I don't want to be misquoted. I fully support the decision to close schools currently because
Yes.
we literally had no choice as a country. Hospitals were overwhelmed, people were dying, and this was the only choice we had.
Right.
But over time, as we learn how to manage this illness, I think we could evolve our thinking a little bit. The second thing is, I think you alluded to, is testing is likely going to be a part of any kind of school opening and keeping kids safe during school. I think testing capacity is going to have to come up significantly.
Yeah. Yeah, no, I think that's right. I think daycare is a little bit tricky too. That's a tough age group, right? I mean, anybody raise your hand if your toddler was a very poor social distancer? That would be me, right? So I think that group tends to be really difficult. It's also a group that I think can't be asked to mask and to do some of the other not great about hand hygiene and other things. So I think there are going to need to be different mechanisms in place. But again, there's absolute acknowledgement that parents have to go back to work.
Yep.
Our society has to function. And so we do need to figure out ways that we can make it work. And again, whether it's some compromised middle of the road scenario where we have kids who are in daycare part of the week or something like that, I think that's going to ultimately need to be the case.
Absolutely, or smaller numbers, but we like to be realists in pediatric emergency medicine, and I think you have to understand that people, like you said, people have to work, people have to earn a living, and if this is what you need to earn a living, then you find a way to make it work.
Right. That's it exactly. And I'm going to toss it right on back to you as we move to summer camp, right? Everybody wants to know about camps, and oh my word, what should we do about that when you're a camp doctor? So what do you got?
Right. So I'm a camp doc. Both my kids are big time campers and dream about it for the months that they're not there, and maintain contact with all their camp friends. My wife is still friends with all of her camp friends as well from Camp Echo Lake. But I've thought about camp for a while, and I've been in conversations with our camp director, and I think camp is a little different than school. I think school is a required part of society, and camp, as much as my kids love it, I don't think it's a required part of society. So we may not be able to tolerate the same amount of risk that opening a camp would do as compared to the level of risk we can tolerate by opening a school in certain ways. The other problem is, especially for sleepaway camps, they tend to, and even just day camps, they tend to involve a lot of contact. You're in very close spaces, you're doing sports, you're breathing hard, you're in contact, and there's just a ton of very high risk activities that take place. And I just don't know if we have the capacity to protect campers. I really don't know. I've struggled with this, and I can't tell you definitively yes or no, but I have deep reservations about it, I think is probably the best way to put it.
Yeah, and I think that we should really all expect that if camps indeed do open, to expect that for there to be some kind of a requirement about testing, and that will be a requirement before, perhaps even during the camp session, depending on how long it is. I think there will be lots of different the activities will look different in camp. It will be a very different experience,
yes.
And I think that's really important to note. In fact, the CDC put out some guidelines just last week, some general algorithm for is a camp prepared and ready to open. It's posted on my social channels. Yeah.
Absolutely. And then I think the other thing to keep in mind is the location of the camp and where
Right.
the campers are coming from, I think makes a big difference. You know, a camp that's opening in New York, which is the epicenter, I think, of the world other than Brazil right now for coronavirus, is very different than opening up a camp, you know, in the Midwest where rates are lower. So, you know, you can't have a one size fits all when it comes to recommending whether to open or not. It depends on the facilities. It depends on day camp versus sleepaway. It depends on where the campers are coming from. It depends when you're opening. Like, there's so many variables in place that affect it. But I respect, I know there are a lot of camps, unfortunately, that have canceled in the last couple of weeks. And I think as the medical community certainly respects those decisions.
Yeah, absolutely. Shifting gears just a little bit, I think we want to talk a little bit about timing of antibody testing, because people asked about that. People think that, oh my word, you know, I was sick 2 weeks ago. I was sick last week. Should I get the test and for kids? So let's talk a little bit about that. Eric, can you kind of walk us through what we know about optimal timing of the antibody testing?
Absolutely. So there was a recent study of about 1,000 patients at Mount Sinai in terms of comparing antibody to PCR. And found that the antibody test that they're using is actually quite accurate. Over, I think, 97% of the sample of the patients who were PCR positive, meaning they got tested when they were sick, ended up generating an antibody response. The key is that some of that accuracy got better over time. And they realized that you have to wait ideally at least 3 weeks for the body to build up this immune response. So we're recommending for our testing, if we get a call from somebody who was like, my symptoms began 2 weeks ago, we say, we're happy to schedule you for an antibody test, but it's going to be in an additional week to make sure you're 3 weeks, because we're trying to maximize the accuracy of this test. So 3 weeks in my mind from symptom onset is the magic number. Any time past that and you're in the clear, and that's the time to get that antibody test. So I know there's a lot of people who felt like they got sick back in February. I would get antibody tested because a certain percentage of them are going to be positive.
Right. Yeah, I think that's great. No, I think that's absolutely accurate. Masks. I want to shift to that a little bit because some people asked about that as well. On the write-in. And first of all, guidance for masks: kids under 2 should not be in a mask. There's a suffocation risk there. The American Academy of Pediatrics has come out against masks for the under 2 crowd, and we support that, of course. It is a suffocation risk. So what in the heck do you do then if you've got to go to the grocery store with your 6-month-old? And that's a reality for a lot of people. It is certainly minimizing going out with a child that age. Keeping them in the infant carrier with the covering. If you don't have one, even a porous blanket is not a bad idea to use to cover the carrier. That's a good way to kind of go in and out really quickly. The older that kids get, people talk about, are there some strategies that I can do to try to get my child to wear a mask? And yes, I think if you make it a game with practicing at home and some positive reinforcement and acknowledging that kids have limits, it is just not in the cards to be able to go and do a bunch of consecutive errands and have a child in a mask for that long. Will kids be able to wear that in schools? I think obviously with younger kids, I don't think that that's a reasonable expectation to have. So that's sort of the primer on that one. The other piece that we're hearing a lot about is, oh my goodness, am I going to have an increased CO2 level from rebreathing if I wear a mask out for a long time? There's a lot of misinformation that's going out on social media right now about that specifically. And I think we need to really dispel that. And I think that the best living example is think of our colleagues in the operating rooms who wear masks for 12-hour cases. Those guys do a transplant case and they do okay. So I think that that's a really important metric to think about and to understand that uncomfortable feeling that sometimes we all feel when we put on our mask and wear it for a long time, that's legit, right? And the reason is that wearing a mask it does obstruct the air flow, not the oxygen, but the airflow. So your minute ventilation, so the number of times that you may breathe, especially if you're walking around and increasing your exertion, that may increase and give you a sensation that in fact, oh, I'm uncomfortable, maybe I'm having a problem with my oxygen, but in fact that is false. The actual diffusion of oxygen and carbon dioxide is that is unimpaired. So masks are absolutely safe and okay to use. Okay, let's dial back a little bit to MISC, because I saw that there were a bunch of questions that people were still a little bit confused about the timing. So can you repeat that? I know I said it the first time through. Dr. Weinberg, you want to sort of go through it. It is not, the MISC doesn't happen during the COVID infection. And so can you sort of repeat that a little bit and the symptomatology there?
So the thought is the MISC is not directly caused by the virus itself, but it's the immune system response to the virus. And as you know, as we just talked about with the antibodies, which is an immune system response, albeit a healthy one, MISC, which is an unhealthy immune response, also takes time. So it's typically a delayed reaction. And that's why we're seeing it now, as opposed to in March in April, when the infections were really hitting at their most. It seems to be popping up weeks to even, a month or two later. So it seems to take time. Now, the hard part is there are some patients who test PCR positive with MISC, and this could be two reasons. One is that we're still learning about this illness, so maybe it can happen early. And two is that the PCR can actually stay positive for several weeks even after your infection is resolved due to residual virus particles in the nose. But really the consensus at this point, for what it's worth, is that it's delayed. It takes several weeks to a month to begin.
Right. And early symptoms, people are asking, what are the early symptoms? These children are having fever. So I think that is the hallmark of that. And many of the cases, there were abdominal symptoms. So abdominal pain, vomiting and diarrhea, even before rash. And so I think that's a really important one to call out as early symptoms.
Again, and I think it's really tough. I mean, the job of parents these days is getting harder and harder. It's not just homeschool, but just trying to figure out this mysterious illness that is poorly understood. Let your doctors figure that out. Let your nurse practitioners and your physician assistants figure that out, because we're still working on it as well. But at least we know the literature. We just put together a guideline for all of our providers, so they know what to do if a patient like this is coming in, and who should be transferred and who should not. So if you're not sure, give us a call in telemedicine, bring your patient in, and we'll check them out. And then we could have an informed discussion and decide the next step.
100%. Yeah, I'm happy to do so. That's called partnering in care, and I think that's incredibly important to do right now. Look, oh my word, it's 10:07. We're staying up late. I think if you guys will hang in there for a couple more minutes, we are trying very hard to get to everybody's questions. Our chat mods, I think, have gotten through over 400 of them, and so we will stay up with you a little bit longer if you guys will too, and try to get through some more of the topics. Okay, so let's talk through again, kind of back to school, a couple of issues. Hot take here on our kids who have been remote schooling and not around in the classroom exchanging germs for the last 2 months. Does that mean that if schools open in the fall, are they all going to get sicker and all be miserable because they're going to be exposed to even more germs? What's your hot take?
It's a good question. Again, nobody can be sure, because I don't know if this experiment has ever been done before. So I guess we'll figure this out. But I think the theory is, we always see in PM Pediatrics in September a very interesting study in virus epidemiology. So typically it takes about a week or two for these viruses to kind of percolate. Yep. And so I would suggest that, especially coming off a vacation like this one, that you'll probably have a week or two, like honeymoon period, we call it. And then, yes, like kids are going to start sharing all the other viruses, adenovirus, enterovirus, rhinovirus, all the viruses that cause common cold, Coxsackie, and so on. And it's going to make our job a little bit tougher, but we're ready for it. We're going to have to try to figure out, what's harmless and which kids are okay and have these harmless viruses and which ones are at risk for something worse. But There may be a small bump in kids who get sick, but I don't think it's going to be any more than the usual.
Yeah,
But
yeah, that's right. It remains to be seen, but I think that is, that's not my biggest concern. What is a concern of mine are kids who are not going to get their well childcare, who are worried about going to see their pediatrician and getting their immunizations. What we don't want to happen is we do not want to create another public health emergency while we are dealing with this one. And what I mean by that is we are starting to see some decreases in immunization rates. And in fact, it makes me concerned that we may ultimately have a cohort of children who may have decreased immunity to very infectious diseases like measles. And we certainly don't want to create more problems than we have. Medical offices, both in general primary care and in acute urgent care and emergency care, have really done a tremendous job making accommodations in the offices to be sure that you can bring your child in and get the immunizations with a very, very minimal risk of exposure. It's safe to do, and I think that it is important to do. Lots of offices are only seeing the well kids in the morning and sick kids in the afternoon, and so they're really separating out those two cohorts. So please do make sure that you are staying on time with your preventive health care. That is a really, really important one. Okay, very, very good. What kind of masks do we recommend? Do you have a recommendation and thought on masks for kids, and kind of masks that you don't need?
So a great question. I think honestly, anything that your kids will wear is a good mask. So I would try to find masks that, interest them in some way, whether it's sports teams or patterns or whatever it is. Look, in a perfect world, a surgical mask is slightly better than a cloth mask, but they're both pretty good at blocking respiratory droplets from going out. And they're both pretty good at blocking you from touching your nose or your mouth. And I think those are the take home. So we have to be realists. And honestly, you have to do what you got to do. In terms of the N95, I think that's a bit of overkill for those who are out in the world. I really want to try to save our N95s, which are still limited, by the way, for healthcare providers who are really getting much higher exposures than the rest of people who are just walking around.
Yep. Yeah. Agree there. All right. Very good. So talking a little bit about the difference between, back to MISC and Kawasaki, the difference there. Want to go through that one?
Sure. So Kawasaki and MISC are a little bit different. There is obviously some overlap, as Dr. Johns explained. So they can both have similar findings of, for example, the red eyes, the peeling hands, the swollen glands, the strawberry tongue, the cracked lips, all that stuff. That's very Kawasaki-like. The big difference with MISC is this myocarditis, which is inflammation of the heart. So with Kawasaki, the main side effect that we worry about is an aneurysm of the coronary artery, which are the very, very tiny vessels that supply the heart with blood and oxygen. And this is prevented with that medicine called IVIG. And then you're fine and you're good. The problem with MISC is you get this myocarditis, which is inflammation of the entire heart. And that causes the heart not to beat as well. And if your heart is not beating well, it causes significant problems with the rest of the body in terms of blood pressure, supply of blood to the brain, and other vital organs. And this is why the kids are ending up in the ICU. So the MISC seems to be far more virulent when compared to Kawasaki. And then it also has some other things that don't really fit with Kawasaki, like the abdominal pain.
Right.
Is not really found with Kawasaki.
Right.
The rash is both, but really the abdominal symptoms is unique to MISC as well.
Yeah, and a lot of people are wondering, is there a sort of an end window that, in fact, after how long do we feel comfortable saying, my child had COVID, but that was 9 weeks ago, so we're out, we're out of the tunnel. We don't know, I think, is the honest
question.
answer.
Unfortunately, we don't know that. I wish I could answer it, and I hope that number comes out soon. And to be honest, I think the amount of intellectual capacity that's trying to figure this disease out is through the roof. And I think we've already learned a ton in several weeks, which I think is unheard of in medicine.
Amazing. Yeah.
I'm very hopeful that we're going to start learning more about what puts you at risk which symptoms are really more concerning than other symptoms. When should you not worry about it anymore? I'm hoping we get that data, but it's just not there yet.
Yeah, agreed. All right, quickly I'm really jumping around here. This is like speed dating with
Let's do it.
questions. Back to somebody wanted to clarify about asthma and the risk there. And if your child has asthma and they get COVID, are they getting sicker than other kids? That data the early data suggests no. That being said, for children who have asthma who require ventilatory support, sometimes that can be a trickier road for those children. That should be stated totally independent of COVID, though. I think that's a really important distinction to make. So that's an important one that I just wanted to clarify.
Absolutely. And
yeah.
one thing along with asthma, I know some people have heard that maybe you shouldn't be giving steroids with COVID, and other people think you should be giving steroids, but really there's no definitive evidence either way. So it's extremely important, if your child is having symptoms of asthma and let's say they're taking a steroid inhaler, keep using the inhaler, really, or if they require steroids to break them out of an asthma exacerbation, that is a good thing. So really you want to control the asthma as well as you can. And I think that sets them up to have a better course if they do end up getting sick from COVID.
Yep, absolutely right. So another thought, people are a little bit concerned about bringing their kids into a medical office, in a medical setting. And I want to talk through that a little bit because I saw some recent data in adults, in fact, but that while overall emergency department numbers have been lower, that in fact there's higher acuity in emergency departments because people are waiting. They're waiting and going in with a heart attack and much sicker than they might have been otherwise. And I really do want to make the point that medical offices have uniformly, ours included, and I'll speak to ours of course, but we are doing Olympics to make sure that our offices are safe and they are clean. We are social distancing in the office. People wait in their cars before they come in. It is absolutely okay for you to come in and have an in-office visit. At this point, we have gotten quite good at really disinfecting and cleaning this and that and the other thing, down to the pens, the way that you get registered, and we're not alone. Medical offices are doing that, and I think that is a really, really important thing.
Absolutely.
I'll speak just really quickly because there are a lot of questions about thoughts about dental offices and orthodontic offices. I think that they are doing a beautiful job too. I'll just tell you this again. This is a personal choice. My kids are going tomorrow for their orthodontist appointment, so I am clearly comfortable enough that they are going. That they're gonna the masking is going to be appropriate. I don't get to go in. I have to sit in the car, and my orthodontist is going to call me later with the report, and I have a relationship with her. So I am okay doing that. I think that I appreciate the concern about the aerosolization and all of the procedures and the dental cleanings that are going on. Again, this does get back to, it's about minimizing risk. We won't be able to eliminate it. I don't know if you have thoughts on that, but I think at some point we've got to keep on going.
Absolutely. I fully agree. I wouldn't add anything other than, obviously it's a personal decision, but I think in general, there's far more danger in terms of withholding routine medical care, dental care, and so on from not going in than going in. I think the risk is going to be quite small at this point, especially with all the measures that are in place.
Right. I think that's exactly right. All right. So back to people asking about steroids. And safe to give. What if you have a child with asthma who is on budesonide, or who's on one of the controller steroid medicine, or in fact who is having an acute asthma exacerbation without concerns for COVID? Are steroids safe to give for this?
100%.
100%.
Yeah. Absolutely. And one thing that could put you at ease, steroids is actually considered part of the treatment now for severe COVID as well. Whether it's MASC, it's in the treatment algorithm, and for adults who have serious illness, it's thought to be due to inflammatory cytokine storm, and steroids actually alleviate this. So
Yeah.
there is it's pretty much universal. If you require steroids for another condition, you should continue those regardless of COVID or not.
Yeah, absolutely. Absolutely right. I'm really going to shift gears for just a second because I don't think we've touched on this topic at all. But I think it is a complication of COVID, and that's the mental health aspect that I think is really, really tremendous. And I'm worried about it. I'm worried about it for my own children and for children that I see, the social isolation issues and kind of ways to deal with that. Any thoughts that you want to share?
I'm certainly far from a therapist or a psychiatrist, but the limited evidence and readings that I've seen is we should be open talking about these things.
Yeah.
Certainly with my own kids, I found if I just ask them how they're doing, or like we talk about how hard this is, my gut is to try to tell them that everything is great and okay, and the sun is shining, and look at all the things we get to do. You get to use your iPad in the morning, and you get to see mom and dad all the time and all this stuff. But you also want to acknowledge the fact that this is hard.
Yeah, it is.
It's really hard. For my daughter, who's a social butterfly, to not see her friends is pain beyond belief, and for those who are anxious or those who have pre-existing mental illness, this is throwing it through the roof. But the good news is the telemedicine is not just allowing us to interact, it's allowing therapists to deliver really good therapy. I know several people personally who use therapists virtually and
Absolutely.
have had really outstanding outcomes from this. So I would avail yourself of it. I think it's a very effective way to do things. And certainly there's child therapists and psychiatrists who are very, very willing to meet via telemedicine if that's your preference.
Yeah, I think that's right. And I have really, when I've talked with kids about who have really expressed their anxieties and things that have been stressful for them, I think part of it is normalizing the conversation. I've really congratulated kids and have commented on how brave they are, that they're speaking up about it in the first place. And sometimes that really opens the floodgates for being able to have a really honest conversation about it. But I think it's on everybody's mind. What is this going to mean for, is there a quote new normal? I know a lot of people don't really like that term, but what is that going to mean for kids and their social development? What's that going to look like in high school if kids are being asked to wear masks all day? I can't quite wrap my head around that at this time. I'm just going to be honest about that.
It's tough. I mean, humans read facial expression. There's going to be a lot of, misinterpreted feelings and statements and so on. It's like you said, it is a new normal. I think it is going to hopefully come to an end when vaccines come to place, and they're already starting, which is good, in terms of human trials. So I think we will come out of this, but we have to adjust to what this is. This is a new normal, and we'll get through it.
Yeah, and we will certainly get through it. And I think maybe what we'll do, my wheels are turning for our next session. And as we get closer to a vaccine, we'll certainly talk about that. We're not going to talk about that now just because it's just too early, I think, to really have a really good science-based discussion. One thing that people want to talk about are swimming pools. And what we know in the early innings, we're not concerned about coronavirus in the swimming pool. What we are concerned about is people's ability to social distance and to do all the behavioral things that need to take place in the swimming pool and on beaches and in the ocean. There's no I don't know of any good reliable data that says the ocean water is safer than the pool water or vice versa. And so I think that is that's not my concern, but my concern really is I don't know if it makes sense to go to a community pool that hasn't made accommodations of whether only a certain number of people can be in the pool and they've got to be far away. I'm trying to really envision how that will work, but those are really the concerns that we have, not about the swimming pool itself, but the people who are there.
Agreed. The CDC actually has a pretty good section on coronavirus and whether there is increased risk in water, and they pretty conclusively say the same exact thing, which is the water, being in the water itself is not going to conduct the virus. It's going to be contact and shouting and other types and violating that 3 to 6 foot distance. That's going to cause problems. But there's nothing inherently dangerous about a pool or an ocean or a lake.
Right.
You
Yep.
can certainly, look, you got to get outside, you got to get out there.
Yep.
You have to do it safe, be smart.
Yeah, that's it. That's exactly right. All right, the last maybe we'll do the last 5 minutes here, and then we'll wish everybody good night. But somebody wanted to hear a little bit more about the COVID toes, and I know that that's been on the news. So can you talk through a little bit more about what that looks like? What's
Sure.
there to do about this? How long does it last? Because it can be kind of a hanger-oner.
Yeah, so it's definitely one of my favorite things to say in medicine, COVID toes. It just kind of flows really
Uh,
nicely.
right.
But, I could tell you personal experience. I didn't have it, but I've seen several patients with it via telemedicine. And the three had the same exact pattern. They were all they were all young 20s. And they were like, I've been running for a while and I noticed that my toes are turning red and I figured it was from the shoes. So I stopped running for 2 weeks and they're still red. And what's going on?
Yeah.
And that to me is a classic case of COVID toes. Just to rehash a little bit. So I think it's another abnormal inflammatory response,
Yeah.
but in a very small way. It doesn't mean you have MISC. That certainly isn't. There has been no connection between
No.
that and MISC. And in effect, actually, patients who have COVID toes seem to have pretty mild illness.
Yeah.
And they may have no symptoms at all, and this may be just like a residual hanger-on
Yeah.
from the virus itself. And you get this inflammation, and
And it's
there's
an inflammation of your blood vessels, right? So it's a vasculitis. So the little blood vessels, it's sort of the inflammation there.
exactly.
That's what causes it to be red. Yeah.
Exactly. And when those blood vessels are damaged, they may leak a little bit. And that's what causes some of the redness and some of the pain and some of the discomfort. And especially if you have like a small decrease in blood flow to the skin doesn't like that. And it may form a blister or other things, even without any kind of pressure. So redness, pain, blistering are all signs of possible COVID toes. And to be honest, if you've had it, I would probably be slightly excited because that means you probably have the coronavirus. I would get PCR tested, and if that's negative, wait 2 to 3 weeks and then get an antibody test. But you
Right.
likely had it.
Yep. Yep. Exactly right. All right. Thought on this one. I just really like this question from Carol. Can you address singing happy birthday? Does singing, can that cause increased transmission of COVID? What do you think about that?
So unfortunately, the answer to that is yes, technically.
Yeah.
So forceful speaking or loud speaking definitely they've done a lot of studies. New York Times has good articles about this. This tends to propel any particles from your mouth a little bit more than just speaking in normal volumes. The worst example of this was in a choir. There was one person who sang in a choir for several hours in a relatively tight space, and I think about 30 other members of the choir got sick because, again, that's a combination of propelling the virus by singing and a very close state. I think if you're singing and you're just around your family, sing away. I don't think there's any harm about that at all. But I think if you're in a closed space with other people who are singing as well, that could be a high risk activity. I don't think getting together in a small room and singing together with people that you're not normally staying with, that could be potentially an activity. If you could sing with a mask, all the power to you. I don't think you could pull that off. But the technical answer is yes, it does actually spread particles farther.
Yeah, that's right. Final question that we have time for tonight, and I promise that if people feel like this was worthwhile and we didn't get to all the topics, we will do this again.
We'll be back.
if you guys would like. But one final comment, somebody wanted to talk about ibuprofen. And again, I think we need to really shut that down. Ibuprofen is an absolutely okay thing to give for kids with COVID-19. That was originally out there that, in fact, the WHO came out saying there may be some concern about using ibuprofen in children. And in fact, that is not the case. They've retracted that statement. Ibuprofen is absolutely okay to use. So I think we need to just say that categorically.
Absolutely. There is not one study that suggests it puts you at any increased risk.
Yeah. Yeah, Exactly right. Okay, look, friends, 10:30. I know it's bedtime for a lot of you. Thank you for staying up with us. One quick way to reach out to get more information and get your questions answered. Again, I'm the senior medical advisor for PM Pediatrics, and so I'm the gal who's out there on social media who tries to connect with all of you guys to convey some info to you. You can see where my social handles are up on the screen right now. I'm on Instagram, Facebook, and Twitter. And a lot of the questions that I saw that were in the Q&A, I put out information like that on my channels on a daily basis. So please feel free to reach out to me there, and I can reach out to the other experts and help try to answer some questions the best that I can. Want to thank some additional folks. Want to thank Dr. Karen Sadow, who is one of our senior vice presidents, Dr. Michael Bachman, Dr. Jan Avarello. Dr. Bachman's another senior vice president. Dr. Avarello is one of our medical directors from Florida. Many thanks. Dr. Bruckner, thank you guys for being in the chat and for participating tonight. What we will do is we will put out a video of this presentation so that you can have a look at the slide presentation and see that. We have done that with our other webinars, and I think people thought that that was helpful. So look for that on some of my social channels. And again, write into me on social. Let me know if you thought this was helpful. How can we make this more helpful to you? We'll be happy to do it again. And so sorry if we didn't get to everybody's question. We got to 500, which is not bad in 90 minutes. And thank you so much for joining us. It's really important to us as healthcare professionals to hear from parents and to hear from families what their concerns are, what they feel like they're not getting enough information about, and we really want to help fill that gap. So Dr. Weinberg, my friend, it is always a pleasure to chit chat with you. Thank you very much for your expertise and wisdom tonight. And everybody, have a good night, sleep well. We'll be back, so stay tuned. Yeah, and stay safe and be well, and good night to you all. Thank you again.
Bye, everyone.